Hello, everybody. I'm up here in Atlanta with Dr. Aryaie, and we're going to discuss some things about achalasia, and we'll take some questions later. He's going to do a short slide presentation over that. So this is Dr. Aryaie.
Hi, how are you? So, well, thank you, Martin, for doing this. And I first found out about this group through another patient. I looked up the achalasia group, and then me and Martin got in touch, and he had a pretty interesting story about, his journey with achalasia and how long it took to kind of get diagnosed, and eventually developed a late stage achalasia where he needed to have esophagectomy to remove his esophagus. But purpose of this is to kind of give you a little bit more information about achalasia, what is the workup, where does achalasia come from, and what are the treatment options, because it's one of those unique, unusual diseases that not a lot of people know about it, even within medical community. A lot of doctors don't really know how to diagnose achalasia. Many times it's mislabeled as another diagnosis, such as acid reflux. So we'll do a little presentation at the end. We'll take some questions here. So sorry for the technical difficulty. We were trying to get this projected a little bit better. We'll be able to kind of maybe rotate the, from this projection. Yeah. So we'll just switch it. See if you're able to switch it there. There we go. So we're located in Atlanta, Georgia. Prior to this, I was in Lubbock, Texas, at Texas Tech University, and I was a chief of bariatric and minimally invasive surgery there, and had patients that had achalasia, and we performed both robotic hilar myotomy as well as perioral endoscopic myotomy. And again, it's a newer procedure for patients that do have achalasia. So what is achalasia? Achalasia is a condition where food gets stuck in the lower part of the esophagus because the lower esophageal sphincter down here in the lower part of the esophagus does not relax. Normally when we swallow food, there is this progression of peristalsis, or movement of the muscle in the esophagus. Then the lower esophageal sphincter that contains some muscle here relaxes so the food can get down into the stomach. But in achalasia, it doesn't happen. It's a rare condition. Approximately 1 out of 100,000 people will get achalasia. There's two kinds. One is called primary, which it is idiopathic. We don't really know exactly what causes it. And there's also secondary, which not very common in United States, but we see that in South America, some of the other countries, due to some of the parasite infections that can lead to inability for the esophagus to have that normal peristalsis to get the food down, and food gets stuck, and that could be a secondary cause of achalasia. We think that achalasia is an autoimmune disorder. Basically, there are some antibodies that are produced that can cause inflammation of the muscle in the esophagus and causes inability for it to work or relax easily. There are also some viruses that are associated with this condition. We don't really know if it's exactly causing this, but there are association that there are some studies been done, especially on herpes zoster virus and measles virus, that there is some data that's shown association between that and achalasia. So many patients aren't really diagnosed right away. Average time for some patients to be diagnosed, depending on where they are and what expertise are around them, it can take sometimes up to 4 years for some patients to get diagnosed with achalasia. And many times it's because there's misinterpretation of the typical clinical features that present, and we'll talk about those. And many patients are mislabeled with acid reflux or gastroesophageal reflux disease. And many times, many other patients keep trying reflux medications for many years. They don't have the proper diagnosis, and that could lead to delay in diagnosis. So what are the most common causes of, or what are the most common manifestations of achalasia? So dysphagia, it's a medical term that refers to inability or difficulty to swallow. Typically, we see difficulty swallowing with solid foods first, then it can progress to liquids. Many patients can also have regurgitation or vomiting up undigested food. Some patients can also aspirate from vomiting up food. There's also some issue with the upper esophageal sphincter. So in the upper part of his esophagus, there is another sphincter that let food down into the esophagus. Sometimes with some achalasia patients, we see they have difficulty belching, or they constantly have to clear their throat. That could be one of the signs that we see. Obviously, substernal chest pain or heartburn symptoms. That's another symptom that we can see with achalasia patients. And some people can have hiccups from distension of their esophagus. And weight loss is also another finding that we see. Not everybody has weight loss, but over 50% of patients can have weight loss anywhere from 20 pounds to 30 pounds within 1 year. So the workup includes EGD or endoscopy. This is done under sedation. We'll put a scope down, take a look inside the stomach. Another workup is called upper GI, which is an x-ray, and we'll give you some contrast to drink. And we'll shoot some x-rays, kind of see how that goes down the esophagus. And to truly diagnose achalasia, we have to do a motility study, which is called manometry. And we'll talk about all these here in a second. So EGD, here's a picture. This is done under sedation. We'll put a scope down through the mouth, into the esophagus, and into the stomach. In some of the late stage achalasia, we sometimes see food just still sitting in the esophagus, and the esophagus can get very dilated. There's certain findings that we see that lower part of the esophagus, especially that sphincter that does not relax, is very tight to push the scope through. Then upper GI, which is that x-ray study that we talked about. We give you some contrast to drink. This is more of a late stage picture that we see with a very dilated esophagus and what we call bird's beak appearance. Down here, it's very narrowed. And that's because the lower esophageal sphincter does not relax. So that's another common findings. But not everybody presents with this picture. This is more of a late stage achalasia. So lastly, manometry, and this is how we are able to actually diagnose achalasia, is a tube that has multiple sensors throughout, and we put it down through the nose, down to the esophagus, into the stomach. I have to warn you, it's not a very pleasant test. I actually did it myself recently because I do it for patients all the time. It's not a pleasant test, but it's one of those things that is necessary to do. You have to be empty stomach for about 8 hours prior to this procedure. We do numb up the back of your nose and your throat when we push this tube down, and the hardest part is actually getting it down. Once it's down, then we have you lay down and we'll give you some liquids to drink, and typically do at least about 10 swallows with this study, and this is how we get these color-coded pictures. And when I look at that, and there are certain pressures and numbers that I look at, and this is how we diagnose achalasia. So based on the manometry, there's 3 different types of achalasia. There's type 1, type 2, and type 3. All of them have lack of relaxation of that sphincter that we're talking about. Type 2, we see increased pressurization within the esophagus, which that can correlate to maybe more chest pain. Type 3, we see more spasms of the esophagus in association with inability for the lower esophageal sphincter to relax. Some of these can be a little bit harder to treat, but now with the invention of perioral endoscopic myotomy, we're able to treat these patients with type 3 achalasia a lot better, and it's a better operation. Type 2 is the most common type that we see. So the treatments, we have come so far from 1600s, where this condition was first described, and Sir Thomas Willis in 1700 used sponge tip whale bone to actually dilate the esophagus. This is when this first procedure was done. But since then, we have come so far And there are multiple different options. Obviously, one option is medications, and we'll talk about the efficacy and whether it works or not. Botox, dilation, laparoscopic or robotic hilar myotomy with partial fundoplication, which means we wrap part of the stomach to prevent reflux, and paraoral endoscopic myotomy, which is the newest procedure, and it was first done in Japan in 2012 by Dr. Aryaie. So medications, one of those medications called calcium channel blocker, or also nitrites. We really have to use high doses of this medication for it to work. It does have a lot of side effects, which can drop your blood pressure significantly, but it's not a permanent solution, and it rarely ever works. So it's extremely unusual that I use these medications for any patients. Botox is also another temporary measure. It's not a permanent solution. We can inject some Botox so it can help relax the muscle that doesn't relax in the lower part of the esophagus. And it usually will require repeat injection every 2 to 6 months. Again, not a great option. We only use this if we have to, for patients that have are not good candidates for surgical option or paraoral endoscopic myotomy, or as a temporary measure for someone to kind of get through a phase till we get them to surgery. It can cause some scarring in the wall of the esophagus, so I do not encourage patients to get multiple Botox injections if they have options of getting the surgical or minimally invasive approach with POEM treatment. Another option is dilation. This was very popular a few decades ago, where again it's a minimally invasive approach. We can dilate the esophagus to starting usually about 30 millimeter, and we can go up to 40 millimeter. As obviously we go higher, the higher risk of perforating the esophagus. Again, the efficacy of this is not great long term. We're looking at this as maybe a temporary measure sometimes for some patients, or if they don't have other resources where they can get hilar myotomy or paraoral endoscopic myotomy. At 1 year, the success rate for the dilation is about 70%, but it drops down to 50% at 2 years. So again, this is another reason that I do not advise this for most patients. But sometimes for some of the patients, again, that are not candidates for paraoral endoscopic myotomy, or patients that are not able to tolerate other types of procedure, it may be a good option. So laparoscopic or robotic hilar myotomy is done through surgery, where we make small incisions through the abdomen, and we go in, we cut the muscle up here in the lower part of the esophagus and upper part of the stomach, so the food can get in there. Now it works well for type 1 and type 2. However, type 3 achalasia responds a lot better to paraoral endoscopic myotomy. The success rate with this at 1 year is about 90%, and we can also sometimes do a partial fundoplication, which you can kind of see the upper part of the stomach we wrap to reduce the rate of reflux. Now, I have to advise you, even with this, people can still develop reflux. In my practice, if somebody has hiatal hernia associated with the achalasia, then I definitely do a robotic approach if it's type 1 or type 2 to reduce the hiatal hernia, straighten out the esophagus, and then do a partial wrap like this. Otherwise, for most patients, I go straight to paraoral endoscopic myotomy, which is this procedure right here, where it's incisionless. We go through the esophagus with the endoscope. We create a tunnel between the submucosa and the muscle layer that does not relax. And endoscopically, we cut all the muscle down here and up. And the reason this is a better option for type 3 achalasia is because some of the spastic condition that patients are having higher up, we're able to actually cut that endoscopically without having a big incision. And then we come out of the tunnel once we cut all the muscle and then close it with clips. There's a special diet that we put you on, basically entails with staying on protein shakes and liquids for about a week, and we gradually advance your diet to advance your diet to pureed food and then soft foods So that way this opening will heal with the clips. And those clips that we put there, it's very tiny, that will fall off after about a month or two. But that's just there to kind of close that opening that we made in the esophagus after we cut the muscle. At 1 year, we see 93% success with this procedure. It's incisionless. There's less adverse events such as bleeding or perforation of the esophagus compared to Heller myotomy. And when we look at some of the long-term studies, we see better outcome with the POEM at 5 years compared to laparoscopic or robotic Heller myotomy. Again, it's more effective for type 3 achalasia. Now, most of the surgical and gastrointestinal societies actually endorse perioral endoscopic myotomy or POEM procedure as a primary procedure as an alternative to pneumatic dilation or surgical myotomy. We also do POEM for patients who have diffuse esophageal spasm or jackhammer esophagus, where there is severe spasms of the muscle within the esophagus that can cause severe chest pain, and it's effective for those patients as well. And I do have some links here that some of the patient testimonial that you guys can type on internet and watch some of the patients that have gone through POEM procedure to get a little bit more information from real patients. So, and this is it. I'm here to take any questions, and I think Martin already had some questions that he was going to ask me, and I think he's been also looking on Facebook to get more information on some of the questions that I can go ahead and answer for you.
I think one question that's on everybody's mind right now, and I would like to kind of put it to rest or give some people an ease of mind, is this COVID-19 and how that is going to affect people with achalasia. I've got some people saying that they're very scared or have a lot of anxiety because of this, and because they have an autoimmune, they're also immunocompromised. They don't want to, they don't want to try to get this. And so,
now, I would say for most achalasia patients, you're not at a higher risk than general population without any disease. Now, obviously, if you have a severe condition where you're severely malnourished because you haven't been able to eat, it'll put you at higher risk because your body's just weak. But for people who have history of achalasia who've been treated, I would say you're not at any higher risk. Now, we all have to exercise, general precautions that we talk about: wash your hands, avoid contact with anybody who's sick, avoid going to the hospital. We are actually right now kind of delay most of our cases at the hospital for the next 2 weeks till this whole situation kind of calms down, and avoid being in public or large gathering to just kind of avoid getting coronavirus in general. But you're not at any higher risk. I would encourage everybody to take their vitamins, vitamin C, daily multivitamins, and vitamin D. And other than that, as long as you're able to get food in and eating, or you're not malnourished, you're not going to be in higher risk.
Okay, well, that's good. One of the questions that we've had before is, why doesn't the surgeries that are provided for achalasia work 100% of the time for everybody?
So, multiple different reasons. Now, it depends on the types of achalasia. We know that type 2 responds the best to out of all of the other types of achalasia to both surgical myotomy as well as perioral endoscopic myotomy. Some people over time can also develop stricture or narrowing in the lower part of their esophagus. Essentially, when we treat achalasia, and whether surgically or through perioral endoscopic myotomy, we're treating one disease and treating it for another disease, which is reflux, because that sphincter naturally would prevent reflux from happening. Now that we cut that sphincter so the food can go down, it causes reflux. Now, over time, reflux can cause stricture. So some people can have recurrence of achalasia because the muscle fuses sometimes and achalasia can come back. but not everybody has that. Some people can develop stricture and narrowing from repetitive reflux, but we can treat that. But that's not always recurrent achalasia. But that needs to be evaluated by an endoscopy, and we've got to see if somebody's truly suffering from reflux versus narrowing from achalasia.
Another question I've had is, once you've had a surgery, or in my case, the esophagectomy, do you still have achalasia? Some people say that they're cured or they don't have it anymore.
So it all depends. So one of the things I should mention is many patients with achalasia don't have a normal motility or peristalsis of their esophagus. So even though the lower part of the esophagus, that sphincter is open, but they don't have a normal peristalsis. So in that sense, achalasia never really goes away. You have to use gravity, basically when you eat small amount of food, even after you had the heleromyotomy or parallel endoscopic myotomy. But you have to sit upright to let the gravity kind of get that food down. Normally, in the normal esophagus, food goes in the esophagus and esophagus peristalsis to get the food down. In a patient with achalasia, that's not normal anymore, or it may never return to normal. Now, some patients that are cut early, I would say, that been diagnosed with motility disorders, that could be early signs of achalasia and treated early. That's possible that they're going to have a normal esophagus again. But for late stage, especially like you went through this, so your esophagus was pushing, trying to get food down through that sphincter for so long that it just couldn't, and it got dilated over time for so long that that muscle wasn't really effective anymore. So heleromyotomy and POEM may still work in that situation, but the motility of esophagus is not there.
Right.
And hopefully we don't see many patients going through what you did.
Right.
And I think there are a lot more information out there for patients to get help, and also more doctors are becoming, there's a lot more information out there for them to learn about achalasia. And obviously, as long as you get in the hands of an expert who's comfortable with reading motility disorders or manometry, comfortable with diagnosing and offer all these procedures, hopefully we should not see many esophagectomies for achalasia.
So another question we've had, and we've had a few conversations here and there lately, is when a patient has a surgery, POEM or laparoscopic HM, why is there occurrence, or why do they have to have another surgery later? In my case, within several years, I went from having a laparoscopic heleromyotomy to esophagectomy within 4 years, basically. And I think some of this is tailored around the spasms and stuff.
So I mean, again, it goes back to maybe the type of achalasia. As I said, before the invention of POEM, we didn't have a lot of options. Everybody was getting a heleromyotomy or HM for achalasia, but if it was type 3, we knew that spasm higher up from where they cut the muscle, it was still there. So that could be one reason that somebody needed to repeat their operation. The other reason is, as I said, the muscle can fuse sometimes, so that contraction can still happen. So some people will require second myotomy, or POEM or Heller, and again, some other people may just have stricture narrowing from reflux. So that's another thing that we need to consider.
So would you classify the fusing of the muscle back or the stricture, would you classify that as a failed operation?
Not necessarily, because there's not a lot that we can do about that, to prevent it from fusing or prevent it from having narrowing stricture from reflux. Now in my practice, I have surveillance for patients that do have achalasia, so they come back and see me every year, once a year. We do EGD to kind of take a look and make sure there is no damage from the reflux, and also to ensure if there is any early stricture and narrowing, we dilate that early enough so you don't have to go through that again.
Okay. One of the other questions we have, and I experienced this on a mass vast scale is, why is it easier for people with achalasia prior to surgery, or even sometimes after surgery, to eat like junk food, not eat a healthy diet? It seems like the candies and the carbs and stuff, it seems those are easier to get down as opposed to, you know, the proteins and the vegetables and stuff like that.
Right. So I would say you're right. Leafy vegetables, meat's going to be a lot harder because even when you chew it, it's still kind of a bulk. But when you have junk food like chips, or sometimes for some people bread, it kind of almost melts. So even if there's a little small opening, it can still get through that area. And some people, you know, sometimes have, you know, carbonated drinks to try and kind of push it down by just increasing the pressure inside the esophagus to kind of hopefully get some food through there. But again, I think everybody's a little bit different. You know, we don't know exactly what's easier. I mean, it might be easier for one patient to have chips and stuff, and then you see another patient that says, you know, this food is not as easy for me to go down. Chips not as easy. So I don't know if there is any specific diet that's going to work for everybody when they're diagnosed with achalasia. Now, I would say the best thing is just get it treated, open that valve that doesn't open. So
yeah, I've experienced that, and I've had talks with many people about, you know, before my surgeries, and actually after my first surgery, popcorn was a no-no. I could not have popcorn. It would throw me into spasms. I would regurgitate more. It was really hard for me with popcorn. So I just eliminated that out of my diet. Now that I've had my last surgery, popcorn's not that big of an issue. I've had people tell me that they can't have hot drinks or hot teas or coffee. Some people can't have cold drinks. I normally drink everything room temperature because it would take me so long to eat a meal and drink stuff that everything was just room temperature anyhow.
right.
So, and that's not, like you said, it's not a common thread throughout everybody that has this.
Right.
So, another question is, why are there so few specialists to treat this disease?
You know, it's such a rare disease that there's not a lot of information on it. Obviously, I was lucky enough to have training in centers that I learned how to read manometries as a surgeon. I learned how to do all these endoscopic interventions as a surgeon, and also have the ability to offer the surgical options. And I kind of developed this special interest over time because I do a lot of other procedures on the esophagus and stomach because you know, this was in a realm of things that I was already doing. But for someone who may just be doing, you know, a gastroenterologist who doesn't focus on the motility disorders of esophagus, or maybe a surgeon who does the surgery but doesn't understand the motility of esophagus, and they get down, they just depend on another gastroenterologist to diagnose it, and they send it to the surgeon to just do the Heller, but the surgeon doesn't understand the motility. That's where confusion comes from. But if you find a specialist, whether it's a gastroenterologist or a surgeon, who has the knowledge of all of it, meaning they read manometries, they do all the surgical options, they do the endoscopic interventions, that's where most patients should try to go. If there's no resources, now a lot of the surgeons are able to do the procedure. But you know, I can tell you, I had patients that were sent to me for diagnosis of achalasia, and I looked at the manometry, it wasn't achalasia. As a matter of fact, 2 patients, I found esophageal cancer. Just looking at the manometry, I said, this doesn't look like normal achalasia. So I went ahead and repeated the EGD and did multiple biopsies. That patient ended up having esophageal cancer. So it's hard. And over time, I think I just kind of developed this sense of, you know, what's normal, what's not normal. Obviously, I've done a lot of reading on this. We are currently working actually on a book for esophageal motility disorders that's designed for surgeons to get a little bit more information on this. So when they're dealing with patients with motility disorders, they have a resource where they can go and learn how to read motility studies for manometry and incorporate that into their practice.
Well, I got one more question, then we'll try to take some questions from the people who are watching. as this progresses through time, and like you showed on your slide, first we had dilations and then the surgery and stuff like that. Where do you foresee this going? And the topic of replacement esophagus transplants has been brought up. Do you think that's a viable option in the future, or is that still kind of so far out of the gamut of our technology and stuff?
Well, as far as so I would say I guess it's you can never say no, it's not a possibility, but there are so many other options that it's available before somebody even needs esophageal, if they ever do it. I know they do a small bowel transplant for patients that are missing their small bowel for a variety of different reasons, but esophageal transplant, that's going to be extremely rare just for this condition specifically. Because I mean, when people get transplanted, it's not just they're replacing and everything's going to be great. They have to be on a lot of medications for that to stay where it is, because your body's going to attack anything that's not your own. So that's going to make you really compromised. But if for somebody who needs esophagectomy, there are other options, like we pull up the stomach. That's called gastric conduit, and basically attach it up here. In a transplanted esophagus, it's never been done, but if it was ever going to be done, I'm not really sure if it's going to work normally, like a normal esophagus. But again, we're still doing a lot of research being done on the basic science side for the GI tract, and hopefully there's going to be better options in the future, or possibly some medication or something that would prevent this from happening.
Questions here? Stem cell research?
Well, there's a lot of stuff being done with stem cell nowadays. They're being injected everywhere. Again, not a lot of studies out there that I'm aware of for achalasia particularly, but again, we're advancing every day in the medical field, and who knows, maybe in 20 years or so we have better answers.
I see the questions. You want me to
Go ahead.
spit them off?
Yeah,
Okay.
yeah.
Oh yeah. I'm going to start from the first person that I saw. It says, how many times can you have a poem procedure?
So I would say safely twice. A lot of times the way I do it, I go, so if you're looking at the lumen of the esophagus, I go on the anterior portion. And if somebody needs a repeat poem, then I go on the posterior portion. And the reason for that is, we don't want to go through the same plane, because that plane is going to be pretty scarred. So the chance of complications is going to be a lot higher. In my experience, patients that needed a repeat poem, the second time did the trick. And most of those patients were the patients that had diffuse esophageal spasms, or what we call jackhammer esophagus, where the entire esophagus just spasms. And I think the one part of the esophagus kind of fuses, so the muscle still contracts. So when we do the posterior one, it can't contract as much to shut down the esophagus anymore. So, but that hasn't been very common, maybe a couple of patients in the past.
So on that topic, with the scar tissue, trying to minimize any scar tissue developing from Botox, balloon dilations, or prior surgery is the key to a better outcome.
With the bone or pelvic myotomy, I would say yes. If you have the option of having these two, and you're in a good medical condition that you're able to tolerate general anesthesia and surgery, that's what I would go for. Me personally, if I had to have surgery or any procedures for achalasia, I would start with the poem procedure. unless I, had a hiatal hernia associated with it, then I would go for robotic Ehlers-Danlos. But as long as you're in the hands of someone who is following up long term and monitoring, because with POEM procedure you can develop more reflux, but as long as you have a good surveillance, and if reflux becomes an issue down the road that you need something done, that's very easy. You can always go in robotically or laparoscopically and create that small wrap on the upper part to reduce the rate of reflux. But even with that, reflux does not go down to zero. So I want everybody to understand that. But you need to have a good surveillance. If you have a POEM procedure done, you need to make sure you follow up with your gastroenterologist or your surgeon at least once a year for the first 3 years, and then every 3 years after that to make sure the reflux is not causing any damage.
And I think that's just in general a good idea, whether you have a regular HM or something like that, is your constant follow-up to make sure that your symptoms are being managed properly.
Right.
One person asked, what should I look for in a surgeon?
So, both POEM procedure or Ehlers-Myotomy or HM, they're going to be done under general anesthesia. With the robotic or laparoscopic Ehlers-Myotomy, as we talked about, you get small incisions, and it's done, through surgery through the abdomen. When you wake up, surgery is done typically 1 or 2 nights in the hospital, and then gradually they advance your diet. You should be able to eat. Obviously, we don't want to wake you up and give you a hamburger. Probably start with some sort of a liquid food and then gradually advance to more solid foods over time. And that's just kind of letting everything heal so you don't have a large amount of food. And then you got a little bit of mucosa there that's holding everything together. And then that could perforate if you have a large meal without it healing. So you want to wait. You don't want to push it right away, okay? And just follow the instructions of your surgeon or your gastroenterologist. With the POEM procedure, in some settings can be done as an outpatient, which means you come in, get the surgery done, after recovery you go home. Most patients end up being in the hospital maybe 1 night. Now the pain, with both of them, you can have pain. With the Ehlers-Myotomy, which is done laparoscopic or robotic, you can have a little bit more pain compared to the POEM because there's no incision with the POEM. With the POEM, you can experience some burning sensation or chest pain right here in the center, which is controlled with some pain medications, and it can go away within a day or 2. And I've had some patients that have a little bit more chest pain or sometimes even back pain after their POEM procedure, and some patients that, they said, I don't even have any pain. So it kind of varies for everybody living this way.
Yeah, all my first 2 surgeries, my laparoscopic and my open, I had minimal to moderate pain. Now my last one, my esophagectomy, that was a whole other book.
Yeah, that's very different. When they go through the chest and they have to cut the chest open, that can be very painful. But I'm hoping that not a lot of people are going to be going through what you went through.
Right.
I think we have a lot more knowledge on this. There are a lot more people that are trained and have a good knowledge of achalasia, and we have better diagnostic tools. Even the manometry, the way it's been done now, we use high resolution manometry. It's different than what was there available 15, 20 years ago. So.
Awesome. And that person did say they're in Georgia, so you should have said they should look for you.
Okay. We'll be happy to see.
The next question, how often should you see your surgeon post-surgery?
So typically after surgery, you will have a follow-up, usually at 2 weeks. That's kind of standard for most people, it should be. And after 2 weeks, if you're doing okay, with me, sometimes I may have you come back and see me at about 3 to 4 months, making sure you have advanced your diet, you're doing okay with that, there's no other issues. And at that point, if everything's good, then we'll see each other once a year. And that's just kind of making sure we have good surveillance as far as doing the EGD, making sure there's no damage to your esophagus, and making sure you don't have any recurring symptoms.
How long does the POEM last before you relapse?
So again, it's a newer procedure. It was first done in 2012, so we're still waiting on longer term, data. In my hands, the first 3 years that I had follow up for some patients, I have not had patients that needed recurrence. As I said, 2 patients that needed redo Poland procedure were the ones that had jackhammer esophagus. So at least the data and looking at literature, I would say 90% of patients, hopefully, for especially type 1 and type 2, will not require any more procedure at least at 2 or 3 years, I would say. Type 3, there is a higher chance that you could have another recurrence. Now, long-term data, even with the Heller myotomy at 5 years, I would say maybe 80% of patients are good, 20% may require some sort of an intervention. But we have to look for the cause. What's the reason that you're having difficulty swallowing? Again, it's not always recurrence of achalasia.
Mm-hmm. And I would say, talking to other physicians and stuff, that the early diagnosis, the chance of catching it early on when there's minimal dilated esophagus and stretching and angulated esophagus is the key to it. So if we can catch it early, get diagnosed early, and have a good procedure done surgically or whatever, then that rate of reoccurrence or having to go back for another operation or something is reduced significantly.
I agree. If you can catch this early, as a matter of fact, recently I had one patient that was referred to me from a gastroenterologist, and she called me. She said, this manometry doesn't really look right. Usually I look at it and I send them to the surgeon and say, do this anti-reflux procedure. And she found out that I specialize in motility. So I looked at the manometry and said, I agree, it doesn't look right. And it doesn't fit that, what we call Chicago classification, basically is what we look for to diagnose achalasia. I said, it doesn't fit any of those criteria. So we did a Botox trial. And again, I don't do a lot of Botox, but if I do it, sometimes in those situations, kind of as a trial. And it worked for her. And to just remind, Botox doesn't work right away. It takes usually about 3 to 4 days for you to see the effect. But now we have her scheduled for Poland procedure to get that done. And I think somebody like a patient like that we catch it early, hopefully we can prevent this from becoming an abnormal esophagus later down the road.
One person says they're from Trinidad and Tobago. They don't have the resources for motility testing to figure out what stage it is. And he says there a way to do self-testing, essentially, to see what type of achalasia.
The type is only diagnosed with manometry. Now, in places, parts of the world that they don't have the resources to do it, the surgeon or the gastroenterologist, they can do the EGD. There are some signs and symptoms that we can kind of see based on the EGD. And also the esophagram or that x-ray with the contrast. Most countries should have that available. That should be one thing that they can at least do. And if it's suspicious for achalasia, again, in the United States, we have all these resources, so we never do operation without manometry. But for countries that don't have that available, I think that's an option. Going to someone who might have a little bit better experience with esophageal and gastric surgeries, and have them do that test. And if it's suspicious for achalasia, they could do that Heller myotomy.
Okay. A few more questions here. Someone said their son had HM done 3 years ago, and now has no contractility. What type of achalasia would that be?
Well, typically type 1 or type 2, those are the patients that we don't see as much motility or contractility. And hopefully your son is doing well at 3 years. For type 1 and type 2, again, HM works fine. But definitely I would say even with that, I would have surveillance.
Another question is, what are the first symptoms that HM might need to be redone?
So typically if you feel like food's getting kind of stuck again in the esophagus, or difficulty passing it down. Those are the first symptoms, just like initial symptoms that you were having with achalasia.
What are we so likely to get? Oh, sorry. Why are we? Well, it's late. Why are we so likely to get diverticulum after HM?
Because the increased pressure in the esophagus, it increases so much, and it can't go out through the sphincter. So it kind of, people get some outpouching of the esophagus, and that's called diverticulum. When patients develop those, and they have type 1 or type 2, and it becomes too big, sometimes we do resect that diverticulum when we do the pelvic myotomy.
All right. Another question is, does a myotomy remove any remaining peristalsis?
Say it again?
Does a myotomy remove any remaining peristalsis?
So in the lower part of the esophagus, where we cut the muscle, obviously the purpose is to kind of relax everything so everything can go through. That part will not function normal, but most patients, again, don't have normal motility to start, or peristalsis to start with. So it does affect it in that sense, but again, most people don't have normal motility of their esophagus with achalasia, so it doesn't become an issue.
Okay. Another question is, they're asking if it's an autoimmune condition, achalasia.
So as I said, yes, we think it's an autoimmune condition. Exactly what causes it, we don't know. There are some viral infections that are associated with achalasia. We talked about, in my personal experience, I've seen a lot of my achalasia patients that also have a lot of allergies, and you said you had allergies. Not a lot of studies done on this, because it's such a rare disease. It's hard to come up with a good conclusion. If it was a common disease, it's very easy for medical doctors and scientists to come up with a reason why things are happening. But when it's such a rare disease, in order for us to come up with something conclusive, we need a huge number of patients to come up with it. But we see association between some of the autoimmune diseases, some of the allergies, some of the viral infections that could lead to achalasia.
There's a doctor in Germany, her name is Inga Skoppel. She did a study on that, and she's written a paper and a study on that, and I can get that link and put that into the group site. I've done that before, and she has concluded with her study that it is an autoimmune. Gene 6 is involved with it, and when that gene is turned on, basically, is when the autoimmune disorders occur, achalasia being one of them. But they just know why that gene is turned on.
Hopefully we get more information in the future.
Awesome. And I guess that kind of relates to someone asked, can you be born with achalasia?
Now, we do see some achalasia in sometimes adolescents or sometimes kids. Again, not a very common condition. There are some motility issues that some kids are born with, but typically we see that in the lower part of the GI tract, such as the rectum and the colon. Not very common in the esophagus, but there are some kids that are born with that.
We've got a couple people in the group that their kids have AAA, which achalasia is part of that AAA. So, and they were young, diagnosed young, really young. So.
Right. Esophageal atresia, that's another condition that we see, but that's not necessarily achalasia. It's just very narrowing, because they're born just that way, that their esophagus is narrow. It's not completely developed where the connection is there. So that's another condition that some kids are born with, but that's not necessarily achalasia. That's atresia.
Someone said, what is the name of the doctor speaking, and where can you find him?
I'm Dr. Amir Aryaie. I'm in Atlanta, Georgia. Our practice here is called Georgia Surgery Care and Ideal Body Institute. And we can post our phone number on there. We are seeing new patients. Our phone number here is 678-466-6760. And it just goes through our clinic, and they'll be able to make an appointment if anybody needs to come and see us.
Awesome. Another question here is, how do we make sure we are getting a surgeon that really knows what he's doing, since it's so rare?
It is. I think platforms like, Facebook support groups like this, where real patients have real results. That's definitely probably the best way, I would say. And then the other thing is, your gastroenterologist, and most likely most of the patients end up seeing gastroenterologists because anybody has difficulty swallowing. Many times they are referred to a gastroenterologist. But one of the things I'm doing, I'm meeting a lot of the gastroenterologists, educating them about all the stuff that I'm doing, so that way they know who they refer patients to. But through this Facebook support group, Martin has names of different gastroenterologists, different surgeons throughout the country that do offer a lot of these different procedures and have some expertise on motility disorders of the esophagus. I would say platforms like this is actually very key. He obviously started this foundation because he went through this and went through this hardship and ended up having a lot more than that he needed to have. But at that point, at that time, there weren't a lot of resources like this. But resources like this is great. And I think honestly, he's doing this on his own time. And I hope there are more people that are going to be donating to this foundation, so you can keep this going and provide information for patients that are out there and really need help to get to the right physician.
Yeah, I found it pretty daunting to do it by myself, not have a resource like this that's available nowadays, and basically taking a stab in the dark and seeing, is this the right guy that's gonna, give me the longest term of relief. And in my case, because I waited so long, because of my mindset, possibly at the time, I waited so long to get diagnosed and treated. I was so far advanced that, I had a laparoscopic myotomy done in 2003. I was diagnosed in 95, and I had balloon dilations and Botox and all that stuff before 2003. I had my lapro done in 2003. 2005, I ended up having an open, different surgeon, different area. One was done in Arizona, the next one was done in England, and I had to search out the doctors. And it's hard to find somebody that understands what is needed and what's going on. And then when I got here in Georgia in 2007, because I was so far advanced, so much damage had been done over the years that I ended up having to have the esophagectomy. So, and I searched out my surgeon. Specifically, I looked for a surgeon who dealt with esophagectomies and had knowledge with Achalasia, because you can have a surgeon that just does one type of surgery all the time,
right.
But if he doesn't understand some of the nuances that go along with why you're at this point, my outcome could have been a lot different. So
Absolutely. Well, on that I would just say search your doctor, see what they do, look at their website, talk to other patients if you need to. But for most doctors that are kind of specialized on this or offer these procedures, they do put it on their website. So, at least that's first step. You want to make sure your surgeon is focused on it and is offering all those different options. And hopefully they have a good understanding of the motility disorders as well. But again, platforms like this is great.
We'll go through a few more questions here. Another question is it possible for achalasia to maintain the same severity, or will it always progress?
So I guess if it's undiagnosed, it will progress. It will not get better. Hopefully, if it's caught early enough and treated, it won't get to a late stage achalasia, also known as sigmoid esophagus, which gets so dilated, and some of those patients require esophagectomy. But it does progress, and if you have any symptoms of difficulty swallowing solid foods or liquids, if you're vomiting on food that's undigested, if you're having chest pain after you eat, those are symptoms that you should be concerned about and get checked out. And hopefully if you catch it early enough, then it'll prevent you from having further issues.
Early diagnosis, good management of it to hopefully give you long-term management of the disease process,
right,
the symptoms over time. And I think that's, to me, is a key to avoid what I went through. If we can catch it early, get to some specialist like you that understands what they're doing and understands motility, does a proper intervention, whatever it may be, on your professional opinion, that they'll have that long-term management where they don't have to go back and repeat things over and over and over again.
I agree 100%.
Another question is, do you develop any food sensitivities post-surgery?
Not necessarily food sensitivity. Some people can have, again, not as common with achalasia, but some people can have dumping syndrome where food rapidly goes in the stomach and empties through the stomach, and people can develop some crampy abdominal pain sensation, or possibly diarrhea, but not a lot of food sensitivity. I would say not. Did you experience any food sensitivity after your first other?
No, I didn't have food sensitivity. I had foods that would irritate the esophagus and cause the spasms and stuff like that. And so it was a learning process. And I tell everybody I talk to, it's a learning process for you. What works for me or what causes me issues may not do the same for you. So, like I said, after my first surgery, popcorn was a no-no. And I had to experience that several times and connect that dot saying, when I eat popcorn, this happens. So we just avoid that. I used to get horrendous spasms. And my way of dealing with it was ice cream. I would go eat almost a half a gallon of ice cream. And most of mine would happen at night, bedtime. So I learned to eat earlier in the night, have a dinner at 6 o'clock to give me time to help try to digest the food or get it into my stomach so it's not sitting in the esophagus to cause that irritation at night. If I did get the spasms, I would be up. I still sleep kind of inclined, but I spent many nights in a lazy boy and eating ice cream just to help stop. And I think that for me, the ice cream was solid enough that it gave something for the esophagus to grab onto and work that spasm out, but it was soft enough where it didn't give me pain. And that was my relief. I passed that on to some people and it works for them, and it doesn't work for others. So it's a steep learning curve for everybody. I can't give you a cookie cutter thing saying this is what you got, this is what's gonna help or not help. So
another question here, can any other condition mimic achalasia?
So there is pseudoachalasia, which typically that's either from the stricture or sometimes some cancers that causes obstruction. So those can mimic achalasia. We talked about Chagas disease, that sometimes we see that, especially South America, from parasite infections that come from ticks. Those can be conditions that can mimic achalasia. Sometimes some patients with Crest syndrome, where they have issue with the collagen depositing within the wall of the esophagus, that basically the esophagus becomes dead, so it's like more just like a stay still tube that just doesn't peristalse. That's another condition that can present similar immunometry findings. Sometimes can be similar to achalasia, but again, there's a slight difference that we can see on there. So those are conditions that can present like achalasia.
Okay, and a couple more questions here. If the I guess they're asking, it's kind of a follow-up question to the one you answered about the symptoms of achalasia. It says, can there be anything done for management if the symptoms do not change?
I mean, the best thing is just get treated, whether it's Horn procedure or Heller, depending on the kind of achalasia you have or resources that are available to you. I would say just get treated. As a temporary measure, as I said, Botox can be tried, but if you have the resources to do other types of procedure that's more permanent, that's what I would go for.
Yeah, try to stay in contact with your surgeon, your physician, whoever's treating you. I know that's hard at times.
Yeah.
Y'all are busy, but try to just be persistent and stay in contact with them and let them know what's going on, and hopefully they can help get you to a better place.
One person is asking if you have a patient from out of state, and they have some issues after surgery, how do you keep them on track? Do you interact with their general practitioner, or what's the treatment plan for that?
Well, I think for any patient who might be coming from out of state, we can always do telemedicine for some of the patients. But as far as the workup, because it's hard for them to come back here and then have all the surveillance, but that'll be the easy part where we could collaborate with their physician there, whether it's a gastroenterologist or a surgeon who's going to be doing the surveillance, and that's not that difficult to manage. We could arrange for that, or if you know someone there that can follow you, and most gastroenterologists are very happy to follow you and do the EGD for you long term. But we can have people come from out of state, and we could always do telemedicine once a year. But as far as later procedures for surveillance like EGD, that can be done in your home state.
Awesome.
Let's take one more question. We can wrap it up for this event.
Okay. There were a bunch of people asking where you were and who you were, so I don't know if you can maybe put that information on the group. But then the last question I see here actually is, did my achalasia cause my Hodgkin's lymphoma?
No, that's completely a separate condition. That's the cancer of lymph nodes, and that's different now. If the lymph nodes are growing around the esophagus, again, that could present like that pseudoachalasia that we talked about that causes obstruction. But lymphoma is just needs to be treated with chemotherapy, depending on what your cancer doctor recommends, and that's who I would see, the cancer specialist who manages chemo.
All right. Well, I want to thank you for
Thank you.
doing
I'm
this.
gonna shake your hand. I'm gonna do that.
Yeah.
Yeah.
I will put links to your practice here,
Thank
your
you.
name, phone number. I will put in some of the other information, links for the studies that we have. I'll put that in there. If anybody wants to contact me through the Facebook to try to get to you, I'll direct in your way. And I think we'll try to attempt this again in another time and expand more of our knowledge on this.
Absolutely.
So I really appreciate your time on.
No, thank you for setting this up and all the stuff that you're doing for all the patients. And it's a great resource for everyone, all the patients that are suffering from achalasia. So thank you.
All right, great. Well, that'll be it for this event. We'll have more in the future. We got another one coming up from some doctors in Texas. Be on the lookout for that. And we'll see y'all next time.